Good morning, everybody.
Good morning, sir.
Welcome to MS Views and News' first program in Pensacola. My name, for those that don't know, is Stuart Schlossman. And for those that don't know, I too have multiple sclerosis. And it was when I developed multiple sclerosis that I found that there was not enough information out there, and I needed to be able to find the information. And as I found the information for myself at the support groups that I attended, I was able to start providing this information to them as well. And other support group leaders from around southern Florida started finding out about the information that I was providing and asking me to send it to them as well. Our list began growing so much so that our newsletters now are reaching people in more than 90 countries. Our subscriber listing now exceeds over 28,000 receiving our information every month. This is a great thing. By the way, once upon a time I was telling people that we have now done over 90 programs. Well, I counted it again this morning to see, why am I still saying over 90 programs? Well, firstly, today is our 25th program of 2014, which is pretty amazing in itself. All right, but we've now, with today's program, 118 programs since we started doing this in February of 2010. Thank you. So, he's the only one clapping. Come on. So, thank you. So, you know, we're primarily in Florida, but last year we got into Atlanta, Georgia, and this year so far, we've gone to Birmingham, Alabama. We've gone to Atlanta again. We've been in Charlotte, North Carolina, and we're going to be getting to South Carolina before the end of the year. We're expanding. We want to expand. And thankfully, to two people that are in this room today, Kenneth and Susan Davis, they are going to be our new operating committee here in Alabama. Well, not here, but right a few miles away in Alabama. All right? So they are going to help us to get the program set up and going around the state, whether it be in Mobile or in Montgomery or in Birmingham, maybe in Huntsville. Maybe we'll get over by Dolphin and be able to get to a little closer to location for where some people are in this room today. And again, the idea is just to expand. Why? Because people need to be educated. We also have people now on the ground in Georgia that are going to do the same as Kenneth and Susan, and they're going to help us expand out in the state of Georgia as well. All right, I don't want to keep going forward and forward here because there's just a lot to talk about. So before we get going into the program, though, I want to thank our sponsors and suppliers of the funding to do today's program. We want to thank Genzyme, a Santa Fe company, the maker of Aubagio, for giving us the grant to do today's program. And I want to thank them, and I hope you all do too. We also want to give thanks to Teva Neuroscience, who is the maker of Copaxone. A 40 milligram formula is now out. For those that don't know about it, the doctor will be speaking about this too. Questcor Pharmaceutical, the maker of Acthar Gel. That will be brought up too. At Biogen IDEC. And Biogen IDEC has a lot of drugs on the market, so we'll just say we have Avonex, we have Tysabri, we have Tysabri Tecfidera, okay, just to name a few right now that are out and about, right? If that's where we're at? Okay, good. So the next one, they have other medications that are also going to be coming out in the very near future, if they're not out already, and we'll talk about that. The doctor will be speaking about all of this. So then we're going to go forward here. I want to just get to what's coming up next. We're going to have 3 different support group leaders. Okay, we ask all the time, all of our programs, we ask the local support group leaders to speak for 90 seconds about their groups, and we're going to ask Eloise Weiser, come on up, Robin and Bill Schatzel to come on up. Robin's from Fairlope, Alabama. Robin is from Shalimar, Florida, and Bill is from Niceville, Florida. So we're going to ask you each to come on up and speak for 90 seconds. After them, we're going to show you a quick 11-minute video about MS Views and News that was just made, and then we're going to get into Brian Steingo's discussion, let him talk, and then the Q&A. Come on down, Weiser. Can you climb up here? You need a hand? 90 seconds. We cut you after that.
I'm the one from Fairhope. I think he said Robin was, but Fairhope, Alabama. It's about an hour from here, going towards Mobile on this side of Mobile Bay. If any of you are from Baldwin County or anywhere near the Mobile area. Anyway, I'm from, like I said, Fairhope, Alabama, about an hour from here on this side of Mobile Bay. We call our group the Eastern Shore MS Support Group because we are the Eastern Shore of Mobile Bay. And we meet on the second Wednesday of every month at 5:30 at Ruby Tuesday in Fairhope, usually with a speaker of some sort, usually a neurologist, and dinner. And we have about 35 or so on my email list in our group. I think the most that's ever showed up at a program was 35, counting spouses and whatnot, usually in the 20s or so. But we would love to have any of you come over at any time, second Wednesday of every month, 5:30 at Ruby Tuesday. And we have free chair yoga every week, every Wednesday at 10:30 at the Methodist Church, and it is provided through a grant from the MS Foundation, so it's totally free. And we have a yoga instructor that they give a supplement for that. So we do that every week too, in a chair, and that's nice. And that's it. Thank you.
Thank you.
I'm Robin McNulty. I'm with the Gulf Breeze by the Sea group. We meet at Gulf Breeze Baptist Hospital on the third Saturday of each month, except for July and August. I say 9:30 to 11, and we usually have lunch to follow. With this group, I usually try to have either a doctor speaker come in or have times where we just do things that are fun. The combined list with Shalimar, since I'm also associated with the group that Bill's going to speak about, we have about 300 of us. I can't get that many to show up at the meetings, though, which I'm really sad. We do this work and then the folks don't show. But most often or not, we do get a good turnout to support each other with our MS, to talk about MS, talk about whatever. So Gulf Breeze at Baptist Hospital in Gulf Breeze, third Saturday of each month. Thank you.
Thank you. Bill. This Bill, not that Bill.
Okay, well, good morning, everyone. I'm going to deviate from this for a second and thank you for bringing this program to Pensacola. This is the first time, as Stuart said, that it has been up here. And I think his MS News and Views offers a wealth of information. If you're not familiar with the site, and I think some in here are not, I'm going to put a plug in to go ahead and do that. So 100 more seconds. Okay. My name is Bill Schatzel, and I live in Niceville. We do have a MS support group, co-led with Robin's Gulf Breeze group, and we meet the second Saturday of every month except July and August, and we meet in Shalimar, Florida. As Robin has also mentioned, we try to get doctors or different companies sponsor items of interest or people to come in and talk to us. Robin mentioned that we have quite a few hundred on our mailing list. Unfortunately, a lot of people do not always are able to attend the meetings. We are very interested in anything new that comes out for MS, whether it be oral or other types of medicine. Obviously, there's no cure yet, but we welcome the doctor to hear also Dr. Steingo, so that maybe we can learn some more from him and what advances are made in the field of neurology. Thank you.
Great, thank you. Okay, so before we go any further and before we get Dr. Brian Steingo to come on up here, who, by the way, I mean, he deserves a major round of applause when he does come because he really battled to get here, big time. All right, so going forward, let's get started with Dr. Brian Steingo because he's got a flight to catch later on, and he's tired, and I want him to come on up here and educate you for the reason why you are all here today. So let's welcome Brian Steingo.
If I start to slow down, it's because last night I spent my night in Atlanta Airport. If you have a night where you're not sure what to do, I recommend a beach hotel, but not Atlanta Airport. So I might slow down as things move on. If I do, just bring me some coffee or something like that. So I've done many of these with Stuart. You saw a brief clip where I spoke there. Fortunately, I had a different shirt and a different jacket. Sometimes I have to think about that. What did I wear last time? Because if I do a few of these on YouTube, you might think I only have one shirt and one jacket. But I did change for this occasion. So sometimes when we do these, there's a number of speakers. Today I'm the only speaker, and we've tried to incorporate what people ask us to do. So in front of you, you're going to see a survey. It's important at the end that you write what you found is good and not good, and what you want in the future, because that's how we sometimes build these up and talk about different topics. And you'll see that there are many different topics we can talk about. And this program that I do, I've called the Land of MS. And in front of you, you see the Land of MS. That's because when we talk about MS, we could talk about each topic over there and spend an evening or a week talking about each individual topic. So we're going to try and pick some of these today to talk about. So we could, for example, talk about how is MS diagnosed? How does MS start? How do we treat MS? How do we treat the relapse? How do we actually treat the disease? We call those disease-modifying drugs or disease-modifying therapies. Or we could talk about your symptoms. We could spend an evening or an afternoon or a weekend talking about the symptoms. That's why in this land I refer to this as the symptom tower, because there are many symptoms. So if you think of a land with a very tall skyscraper, that's because there are so many symptoms that we may have to talk about. And then I talk about other things, medical support. We might have an ophthalmologist with us sometimes, or many other medical support people on your team, such as the urologist and the psychiatrist maybe, and a physical therapist and an occupational therapist. There are many other people that are important. And most important, social support. The support group, whether it's this type of meeting, which I consider to be support, or the National MS Society support group, or the MS Foundation support group, I think support is very important in MS. It's very good to have some support. And people that have good support generally do better than people that don't. And finally, this last topic of self-help. That's something I'm going to spend some time talking about, because I think that's essential. For this land of MS to move successfully forward, the self-help program is essential. I'm just going to build this slide up. So this is the introduction that I'm going to talk to you about, is what is MS? And so we'll talk about this briefly. When you go to pharmaceutical company programs, the FDA often mandates that in every pharmaceutical program that there should be some discussion. And so I'm going to discuss this in my own way. This is a little cartoon I dreamt up myself one night, probably another night when I was sleeping at an airport somewhere. And so this is what it is. So what is MS? MS we consider to be an autoimmune disease. The target of the autoimmune disease is the central nervous system. So the brain and the spinal cord and the optic nerves are the target of MS. But the actual problem with MS is in the immune system. The immune system malfunctions. And in the case of MS, the malfunctioning is attacking the central nervous system and causing MS. If the immune system malfunction attacked your joints, you might have rheumatoid arthritis or some other autoimmune disease, lupus, Sjogren's disease, other diseases you might hear about. But in MS, the specific target is the brain and the spinal cord and the optic nerves. And something triggers off. So you see over here on the left-hand side, something triggers off the immune system. And the components of the immune system that are activated are called lymphocytes. Lymphocytes are a type of white blood cell. You've heard about them. There are T cells and B cells. But the immune system is activated. The lymphocytes are stimulated. And then they have to get through a barrier to attack the brain and the spinal cord, and that's called the blood-brain barrier. And these are all different sites of where things can go wrong. And in the treatments that we have, some of them work at different sites. Some treatments work at the lymphocytes, some treatments work at the blood-brain barrier, and there may be some treatments that work directly in the brain in the future. So they're all important sites. So let's go to the next slide. What are the triggers for MS? So we know that there are definitely genetic factors in MS. If someone in your family has MS, if your parent has MS, your risk of getting MS is probably 30 to 40 times higher than the general population. That's a significant risk. And if you have an identical twin, the risk might be even 40%. So there are definitely genetic factors in MS. So if you have a susceptible person, you're genetically susceptible, then something else triggers off the MS. And what is that? We don't know. We're learning about some of these triggers. It could be an environmental trigger, because we know that people born up north in northern latitudes have a higher risk of MS. If you're born up north, whether it's North America or Northern Europe, you have a higher risk for developing MS. So environmental factors. Now another one is vitamin D. So vitamin D deficiency. At one time they used to say, well, if you're born up north, there's no sun, so you might be vitamin D deficient. But now we know that vitamin D deficiency is very important for MS. And I hope everyone sitting here is taking vitamin D. A very important trigger, very important to check vitamin D. And in adolescence, if you have adolescent children, and it seems to be an important trigger, if they're susceptible already genetically, their vitamin D is very important. There are some other triggers, like smoking. And as we go along, we'll talk about some of the triggers. So once you have these triggers, whatever they may be, including infections like mono, this trigger with the genetic susceptibility is what triggers off the MS. And so the lymphocytes, I told you there were T cells and B cells. something's going to happen here. You have to pay attention to this slide for 1 second. Ready? Okay. So that's what happens. The trigger activates the lymphocytes. They have to cross the blood-brain barrier and attack the central nervous system. So this is kind of what happens in MS. And if you close the blood-brain barrier, and there are some drugs that work at the blood-brain barrier, Tysabri is the best example, then you may prevent the attack on the central nervous system. Other drugs work in different places. So I'm summarizing over here what happens in MS, because we have opportunities here you'll see in the treatment. So the first thing that happens in MS, like I said before, you have a genetically susceptible individual, and some triggers, you then are exposed to some triggers. The trigger could be low vitamin D, it could be an infection, it could be an environmental factor. We don't know all the triggers, but there are some triggers. And the triggers activate the lymphocytes, which then attack the target, and the first step is inflammation. Inflammation is the early part of MS. And when there's inflammation, we have an opportunity. If we diagnose it early, we can shut down inflammation and hopefully prevent further damage and even maybe allow some recovery to take place. After the inflammation happens, the myelin that covers the nerve is damaged, and even still early on, if the myelin is damaged early on, it may still recover if we stop the process early on. Because if the process continues, then the nerve may actually be damaged. That's called the axon. The axon is the nerve. If the myelin is damaged, there is potential for some recovery. If the axon is damaged, it is irreversible. The axon cannot recover. That is when you see permanent damage. If you look at a scan, you see atrophy. So clearly, we want to treat early on before this whole cascade of events has taken place. The earlier we treat, the more likely we are to prevent the degeneration and the atrophy that happens later on. So one of the things we have talked about recently is the invisible symptoms of MS. So I've listed for you over here now, going into the symptoms, and I said we could spend all night talking about the symptom tower. We're not going to do that. You know the symptoms of MS. There are many symptoms of MS over here. Now, some of these symptoms are more obvious than others. If you have trouble walking, that's not invisible. If you have a speech problem, it's not invisible. But there are certain symptoms of MS that are invisible, and that was one of the things that we've been talking about lately that people requested, and that's particularly what I'm going to talk about now, is the invisible symptoms of MS. And they're particularly important because if you look at them, they are often the most disabling symptoms. Sometimes the symptoms that you see are symptoms that someone can deal with easier. For example, if someone has trouble walking, they might be able to get a walker or a wheelchair and maybe even continue to function and go to work and go places. But some of these visible symptoms are much harder to manage. So this is an invisible symptom. This is the symptom where someone looks at you and says, well, you look good. People will look at you and say, but you look so good. The MS Society actually made a brochure that says that. You look so good. You might have fatigue. How does someone know if you have fatigue or pain or some of these symptoms we're going to talk about? So the invisible symptoms are very important, often the major cause of disability. In fact, the major cause of disability in a young person with MS, the major reason the young person with MS leaves the workforce is because of these invisible symptoms. That's why sometimes if you go to Social Security office or speak to someone in Social Security, they don't see a problem. And they judge. If you go to Social Security office, they'll judge you. Even the opposite way. They judge walking particularly. I had a patient the other day who went to renew her driver's license, and she walked in with a walker and they refused to renew it. She got something from the Florida Highway Department to say that, we got to check her out because she doesn't walk well, therefore she can't drive. So people make judgments. So the first symptom we're going to talk about is fatigue. Very important symptom. The Social Security Administration even recognizes this as a symptom of MS. It's a lack of energy. How do you describe fatigue? Everybody has fatigue sometimes. You're tired. If you don't sleep all night because you spend all night at Atlanta Airport, you're fatigued. So I know how fatigue feels. But it is something that interferes with your activities. Now look at the bottom there. It's not laziness. How many people here are lazy? Nobody? Wow. How many people have been told they're lazy? That's the better way of saying it. How many people have been told they're lazy? You're not motivated. How many times I see that in the office? Doc, she just needs to try harder. She just doesn't try. Is it laziness, lack of motivation? For psychological? How often does that happen? This was a much bigger problem in 1980 because in 1983 MRI scans came about. And MRI scans said, this crazy woman that says she's dizzy and fatigued and has a loss of memory is not really crazy. There's something wrong with her. She got MS. Because before those days, people were often told when they had MS and they looked good, well, you need to go and see a psychologist. There's nothing really wrong with you. This is a fatigue severity scale. I just put one in. There's multiple fatigue severity scales. But we can fill this in. I like to fill this in, especially the first time I see someone, and periodically after that. It's a way for us to measure the fatigue. And it goes from 1 to 7, 7 being the worst. So you could say, does the fatigue affect your motivation? Does exercise bring it on? Are you easily fatigued? Does it interfere with your physical functioning? Is it a disabling? So many different questions. And as you heard before, all this stuff that I'm talking about, if you want to spend more time looking at some of these things and the importance of them, they all are, this is posted on YouTube and you can spend time looking at it. And there's two types of fatigue to know about with MS. There is the primary MS fatigue. That's the fatigue that you have just because you have MS. It's the fatigue where you wake up and you may have had a good night's rest even and you're tired. It's the fatigue we don't understand well. Is it due to a lesion in a specific part of the brain? Is it due to chemical factors? We're trying to find out what it is. We don't know. It's the primary MS fatigue. But it's very important when you have fatigue that we evaluate what could be causing your fatigue. Could you have secondary, let's see if the pointer's working here. Could you have secondary MS fatigue? Because if you come into your doctor and say, I have fatigue, and he says, well, take some Provigil, that's a disservice to you. That's the easy way out. That's, he has to go home and watch, my LeBron James playing or something. You've got something else in your mind. You want to get out of there. So what I need to do is I need to interrogate you and say, could there be something else causing your fatigue? It's a complex issue. Could you have weakness? Could you have deconditioning? Could you have bladder problems? Could you have bowel problems? Could you be heat sensitive? Could it be a medication side effect? You just started a new medication for your bladder, for depression, for something else that makes you sleepy. It adds to your fatigue. All these things add up. And maybe I can improve your fatigue by taking care of some of these individual problems before I say at the end of this, okay, we've done everything we can for your symptoms. You're not sleeping well. Look how all these things are related together and interact. Everything interacts. You have a bladder problem. Well, guess what? You don't sleep at night. You have spasticity and spasms. You don't sleep at night. Therefore, the next day you're tired. You're fatigued. You're cranky. You're fatigued and you're cranky, so you're more depressed. I mean, there's interaction between these things. We constantly need to be aware of interactions of symptoms and medications. And could you have another medical condition? So people with MS, one autoimmune disease, others are more common. You might have thyroid disease. You might have an underactive thyroid. We should check out your general health as well. We should never forget your general health. And here are some of the medications I listed. We won't spend a lot of time on medications. Amantadine is an old medication. Actually, originally was an anti-flu medication. And now we use, if that doesn't work, we use stimulants such as Provigil, which most insurance companies fight with us about. It's a constant battle. And then stimulants such as Ritalin and Adderall, other stimulants. So there are some medications, but I'm not speaking long about them because all the other things need to be evaluated. We need to say, why do you really have fatigue? Is there something else going on? And then sleep in MS. It's another symptom that's important to manage in MS because it interacts with everything else. Now, I haven't gone to all the things about sleep over here because I just spoke about some of them a minute ago. I just said, if you have a bladder problem and you have to get up 3 times at night to go to the bathroom, or you have pain and spasticity, all these things interact and disturb your sleep. But there's one specific part of sleep that I want to talk about over here, and that's sleep apnea, so-called obstructive sleep apnea. And you can see that it occurs in a significant number of people with MS. And here's some risk factors. This is a questionnaire. It's called the Stop Bang Questionnaire. You can see it's an acronym where the S stands for snoring, tired, observed apnea, blood pressure, BMI, your body size, age, neck circumference, and gender. All these things are important things. So if you're a male, for example, and you're overweight and your neck circumference is over 16 inches and you snore at night and someone observes apnea, you have a high chance of having sleep apnea. And what's the importance of sleep apnea? Sleep apnea is associated with a higher risk of heart disease and strokes. Think about that for a second. So the next question is, what about strokes and heart disease in MS patients in general? Do you think that's higher or lower? And the answer is it's higher. MS patients, like you haven't got enough to deal with already, have a higher history, a higher risk of cardiovascular events and strokes. This was a study that published just recently, within the past year, from the Swedish Medical Institute. They published a study and showed that people with MS have a higher risk for vascular disease. And so this goes, you see my theme going through that I'm talking about, take care of your general health. Because you have MS, we need to check your lipids, we need to check your cholesterol, we need to check your blood pressure, we need to make sure you're not diabetic. We need to keep on top of all those things. You need to have a good primary care physician that's going to work with your neurologist. So we go right back to the beginning of the land of MS and the medical support. And you see how everything is interacting. It's very important always to keep that in mind. And now what about pain? So some of you may have known that there was a time when they said, You don't have MS if you have pain. MS doesn't cause pain. Of course, that's totally false. And you can see that MS can cause different kinds of pain. So there's firstly musculoskeletal pain, muscle pain, spine pain, joint pain. And then there's neuropathic pain. That's the direct result of the damage to the nerves. It's a different kind of pain. Neuropathic pain is often the burning, tingling, sharp pain. And then pain can happen in different ways. It could be acute. It's a very sudden pain. Or it could be chronic. It lasts there for a long time. Or it could be what we call paroxysmal. It means it comes and it goes. The classic example of that I'm sure some of you have, is trigeminal neuralgia, facial pain. It comes and it goes. It's very sharp when it comes, but it comes and it goes. Whenever we look at pain, here's another acronym for you. You'll see as we go along here that I love acronyms. And here's the acronym of OLD CART. When you come in with pain, I'm going to ask you these questions. When did your pain start? What's the location? How long has it been there? What's the duration of the pain? What's the character? What kind of pain is it? Is it an aching pain? Is it a sharp pain? Is it an electrical pain? It might help me determine if it's a muscle pain or a nerve pain. What aggravates it? What makes it worse? And what makes it better? Aggravating and relieving factors. And how have you treated the pain? What does it respond to? What kind of treatment? So this is just a little background on pain. And this is talking a little bit about musculoskeletal pain. Typical example, commonly seen in MS, muscle stiffness, which we call spasticity. And with that, you may often have muscle spasms. You could have joint pain. Now, MS itself is not a disease of the joints. If you have a specific joint problem, that is not due to MS. You could have another autoimmune disease, rheumatoid arthritis or some other autoimmune disease. Or because of your MS, you might not walk properly. You might have trouble walking. You might have a limp. You might use a walker. You have some assistive device. It puts abnormal stresses on your joints. Your knees, one knee might be better than the other because you favor one leg. So because of that, one knee might be under pressure, one hip might be under pressure. Your back could be under pressure. You could have back pain. So there's a lot of potential joint, back, and joint pains that could happen as a complication of the MS. And headaches. Headaches could occur because you've got neck pain, you've got stiffness in your neck. In general, we do see more headaches in MS, and why is that? MS is a disease that is more common in females by about 3 to 1. Migraine is much more common in females than males, 9 to 10 to 1, much more common. Therefore, it's not unusual that we see more headaches. Most headaches in people with MS are due to related factors and not directly due to the MS. Here's a little section on the neuropathic pain. That's the classic pain. If you say you have burning, tingling, electrical, sharp pains, that is a neuropathic pain, an electrical type of pain. And it could be sensitive to touch. You touch the area, it feels cold, it feels uncomfortable, it feels sensitive. And it's often worst at night and keep you up. Trigeminal neuralgia, I told you, is an example of a pain that comes and goes, often very sharp kind of pain that comes and goes. And many of you, I'm sure, are familiar with something called Lermit's sign. I'm sure some people have had Lermit's sign, and that is a sign that's common in MS. And it happens when you bend your neck down. If you flex your neck down and you feel a tingling sensation or an electrical sensation, it may run down your back or down your legs or down your arms. It's a common sign with MS. It can be seen with other conditions too, but it's common with MS. And then the MS hug, which is a hug around you. You feel like there's a tight constriction around your chest, so-called MS hug, which can be all the way around or just on one side. So there are many different kinds of pain that we need to be aware with MS. And why is it an invisible symptom? Because nobody else can see your pain. It's a very subjective thing. Like I said right at the beginning, pain has emotional and physical implications. It's hard to measure on pain. How do we treat pain? You'll see there's 2 groups of medications over there for pain. The first group are the anti-seizure medications. So gabapentin, which is Neurontin, Lyrica, carbamazepine, which is Tegretol, and oxcarbazepine, which is Trileptal. These are all the seizure medications that are helpful for neuropathic pain. And then we use the antidepressant groups. The oldest one is amitriptyline, which is Elevil, which has been around forever, and it's been replaced by some newer medications like Cymbalta, which also helps neuropathic pain. So we go through this whole sequence, and in most people we can get some benefit with these because we don't want to resort to using opioid medications. That would be very rare. By that time we'd have to refer you for pain management. And this is the musculoskeletal pain. So the non-steroidal anti-inflammatories such as ibuprofen or Advil or Celebrex do not work for nerve pain. Neuropathic pain we just talked about, the non-steroidal anti-inflammatories do not work for that, but they do work for musculoskeletal pain. You certainly can try them. And you can try the antidepressants as well. They may work as well for this. Antispasticity medications, baclofen or tizanidine we may have to use. We can use Botox sometimes to help muscle spasticity. It's quite effective in some situations. And then, of course, it's very important to use non-pharmacologic measures, going back again to the support you have. Physical therapy, occupational therapy, massage therapy, acupuncture, all those things might be of benefit. And the very last resort for managing pain is to use opioids. That would be if the pain was not responding to anything else and it was disabling. There is some evidence that opioids might actually not be good for the immune system, but sometimes we're desperate and we have to use them. So here's another immune system, another invisible symptom, I should say, which is cognitive function in MS. So there's different studies. Some studies say it occurs in 40% of people, some say 65% or more, but it's an important part of MS. As I said before, often a very disabling symptom. It can occur early. So they've looked at people early on, even newly diagnosed sometimes, and they check them and they already have some cognitive dysfunction very early in the course of their disease. So here are some of the functions that can be affected cognitively. So it can be the memory, short-term memory, retrieving new information. We know that memory can be affected. Attention and concentration are affected. Information processing. So we know that processing is a problem. Executive functions, planning and prioritizing. One of the biggest issues that people speak to me about. They become very disorganized. Sometimes they say they were organized, now everything's chaotic and disorganized. Bills are unpaid, things are lying around. Visuospatial functions, visual perception, verbal fluency, word finding, and all this information I took again from another publication of the National MS Society. So you'll see things with MS. So when someone has cognitive dysfunction with MS, how do we evaluate that? We might send you to see a neuropsychologist to try and get that evaluated and pinpoint your specific deficiencies. Is it memory? Is it processing? Is it multitasking? Is it attention and concentration? Is it word finding? Let the neuropsychologist help us with that. The neuropsychologist is particularly important if you're about to apply for disability and your major reason for disability is memory problems. Because if we tell them you have a memory problem, they just ignore that because it's subjective, it's what you feel. So we want evidence with detailed memory testing, neuropsychological testing to show that there's an issue. And then what the neuropsychologist also helps us with is maybe to plan how we can help you with your memory. Do maybe cognitive rehabilitation. Teach you things to do with your memory. Because there is no effective medication for memory loss of MS. Medications that have been tried include things like Aricept, which is used for Alzheimer's disease. It really doesn't work. There's no good evidence that it works. Some studies said yes, some said no. Whatever did minimally, so we have no good medications. Supplements, ginkgo, things like that have been tried. No really good evidence that any of those things work. So what you do when you have a memory problem, the most important thing that you need to do, some of the things written down over here, mental stimulation, word games, keeping your mind active, stimulating your mind every day, just like physical exercise is very important. So if you go down on that list, you'll see self-help techniques, becoming organized, and a neuropsychologist can teach you things to do, strategies to do, how to make notes, how to become organized, how to do one task at a time, and let people know around you. Let's not be cluttered, let's do one task at a time. So self-help, mental stimulation, using any of these methods up there, physical exercise is very important as well. And everyone can exercise. Even if you can't walk, there are seated exercises, there are arm exercises, there are things you can do. You have to keep your body moving. It's important to keep it moving whatever you can all the time. And then cognitive rehabilitation, where an actual trained neuropsychologist can teach you some strategies as to how to compensate with your cognitive function. Exercise is physical and mental. And they've shown physical exercise may be as important as mental exercise for your memory. There are multiple studies published with that. And so physical exercise, if you can't do a lot, then I don't expect you to do a lot. Exercise could be hard. You have to be motivated to do the exercise. It's very hard. You might get hot. You might heat yourself up and say, I can't do it, I become overheated. And the response of some people is to say, I'm hot and I'm weak and I'm stopping and I'm not doing it again. And I would say, no, we need to compensate for it. Do it in a cool room. Turn the air down. Put on a cooling vest. Drink a cool drink. Limit your exercise. Instead of doing half an hour, do 15 minutes, do 10 minutes. Whatever you can do. Some exercise is a million times better than no exercise. And these are some of the things about exercise. You need to want to do it. You need to be motivated. I think that's probably the most important thing there. It needs to be available. So somebody needs to teach you. I like everyone to see a therapist at the beginning. And for the therapist to teach you what you can do. Evaluate what your skills are. What can you do? So you emphasize the things you can do. Should be affordable. At the beginning, we need to get some exercise for you. And hopefully your insurance pays. If it doesn't, we just see if we can get you a grant to get you some exercise. Other than that, a lot of exercise, just moving around, can be done in your home. convenient and enjoyable. I mean, these are the ideal things. But we're trying to make exercise just part of your life, part of your lifestyle. These are some of the exercises that I emphasize. Balance where it applies. Endurance, people get tired. Endurance, stretching, strengthening. We talked about cool environment, dress cool, air conditioning, cool beverages, spray misting, some of the techniques to help you do exercise. Because that's one of the things that's very important. It's one of the questions I ask every patient every time I see them. Are you exercising? Mental and physical. Cool. And I also ask them, one other thing we've done before, and we'll talk about them again maybe later if we have time, is, are you taking your vitamin D? Yes? One taker. Vitamin D, I should rather say, in a group like this, I should say, who isn't taking vitamin D? If you are brave enough to admit it, you should all be taking vitamin D. Yeah, we measure your level. We can't tell you until we measure your level. So here we go now. We're in the land of MS. We've gone back into the land because now what we dealt with was we looked at the symptom tower. We said there's many symptoms. This is not a meeting where we're intending only to talk about symptoms because we could spend time talking about all of them, bladder and bowel and everything. And so we talked about the invisible symptoms because they're so important, such an important factor in contributing to the disability of MS. And now we're going into the land of MS and saying, what kind of MS is there? What types of MS are there? And so classically, you know, we've always said that there are 4 types of MS. You see over there the bottom 4 types. So relapsing remitting MS is the commonest type of MS. 85% of people or so start out with relapsing and remitting MS. Now, what that little arrow shows you is that without treatment, relapsing and remitting MS has a risk of developing into secondary progressive MS. And we'll talk more about that in a second. Some people start out with primary progressive MS. The MS progresses right from the beginning. And then there's a rare group where they have a progressive type of MS, and then out of the blue, they may have a relapse occasionally. That is called progressive relapsing MS. Now, you'll see 2 newer types on top over there that some of you may be familiar with. So, look at the second item, clinically isolated syndrome. So, typically over the years, in order to diagnose MS, we say, you have to have 2 events separated in space and time. That's the way we've always diagnosed MS. 2 events separated in space and time. And the second event could be another event that you know of, a clinical event, something happens to you, or it could be a new spot on your scan. That would be a second event too. But when you have your very first symptom, we call it a clinically isolated event. So if your first symptom, for example, is optic neuritis, it's not you haven't had a second event. We might look at your scan and say, wow, you've got a couple of spots. It looks like you have a high risk for developing MS. So really, it could be your first symptom of MS, but we call that a clinically isolated event. Now let's go back even before that. You bumped your head. Somebody hit you on the head. You got a headache. You went and had an MRI scan, and somebody said, wow, this scan looks like you have MS. And you have absolutely no symptoms of MS. That's called a radiologically isolated syndrome. And we do see people like that are sent to us just for an evaluation. They have a scan that looks like MS, but they've had no symptoms of MS at all. So even early on, sometimes we're able to say this person is at risk for MS. So if you look at someone's scan, they have a brain scan, it looks like MS, we then send them for a cervical scan, a scan of their neck. If that scan shows lesions of MS, then they have a very high risk of going on to develop MS. So these are stages of MS. All the clinical trials show that if you treat people with CIS, so even when they have their very first symptom, if you treat people with MS, then what you do is you reduce their risk of developing the second event. You delay the time before they get the second event. Remember I said the way you diagnose MS is when you have the second event? So when you treat them right from the beginning when they have a clinically isolated syndrome, you slow down, the second event is delayed, and the progression is delayed, a delay in physical disability as well. So this is why we recommend early treatment as soon as we diagnose a clinically isolated syndrome. These are some of the goals of treatment. These are the obvious goals. And anytime you take any medication, you need to say, does the medication do these things? Does it reduce the frequency of relapses? Does it slow the progression of disability? Does it have a positive effect on the MRI scan? And then, of course, you want to reduce all the symptoms. You want to reduce all the morbidity from the symptoms. We want to make sure you take your medication, and we want to make sure that it remains safe and efficacious, that it continues to work over a long period of time. Yeah. If you have MS and you're newly diagnosed, or you've had it for a while, you say, is there some way that, thank you, is that better? I guess that's better, yes. Is there some way that we can predict how the MS is going to turn out? Now, you all know that MS is an unpredictable disease. Everybody does differently. You can look at two people who start the same day, and 10 years later, one person might be unfortunate enough to be in a wheelchair, another person is able to run a marathon, for example. It's a very different disease. There's probably different things that happen, and MS is different in different people. But we get some indication by looking at some of these things over here. So, for example, the age is important. The older the onset is an important factor. The symptoms at the onset. So if you have optic neuritis, that's not a bad symptom to have as a starting symptom as compared to someone who starts out, for example, with something in their spinal cord where they might have right from the beginning trouble walking and a bladder problem. And then the MRI scan. The number of spots on the MRI scan could be important. And then the period. How often do you have relapses and what's the period between them? So in the first 2 to 5 years, the number of relapses, the time between them, and the amount of recovery from them are all important factors. So here's some things we can look at, 6 different items, and then we can put them together and say, looking at this, we're concerned that you could have a more aggressive type of MS or a more active type of MS, and we're going to recommend more active treatment. Whereas if you have fewer of these, you have one episode, you don't have another one for years, you recover well, your scan doesn't show very much, you're clearly going to have a better outcome than the opposite of that. And this shows you something with the MRI scan. How does the MRI scan help us? So if you look on the left-hand side, what they looked at is they looked at people with, remember what I told you, clinically isolated syndrome. Somebody had their first episode. So let's take the example of someone that has optic neuritis. They come in and they have optic neuritis, and we look at their brain scan, and we say how many white spots or lesions or plaques, whatever name you know them by, and they have 0. Let's say they have 0 white spots. You have optic neuritis, you've got no white spots in your scan. What's your risk of MS over the next 10 years or so? It's about 20%. So even if your brain scan is normal, you still have a risk of MS. How about you have 1 spot? What's your risk? 80%. How about if you have 10 spots? What's your risk? 80%. So no spots, you have a low risk. Even one MS-looking spot, a spot that is characteristic of MS, even one of them, you have a risk of going on over the next 10 years to develop definite MS, which means you have another event or more events. So what does the number of spots tell us? Or if you look at the right-hand side, now you look at what the number of spots means. The more spots you have at the beginning, the more likely you are to be disabled over time. So the number of spots, all that does is tell us, the number of spots tells us what your risk is over time. But even 1 spot means there's some risk for MS. So that's how an MRI scan, right from day one, is going to give us some information. So this is what happens if you don't have treatment now. Remember right at the beginning of introducing this section, there was relapsing-remitting MS and a little arrow pointing to secondary progressive, and we said that about 10 to 20% of people have what we call benign MS. These people have little disability, you can't even tell. You know, there are people that say, wow, you already have MS, you can't even see it. You can't tell this at the beginning for the most part. We can have some indication from what I said before that someone looks like they could have a mild course, but generally we want to wait and give this kind of definition about 10 years. At about the 10-year mark, we want to say, it really looks like you might be fortunate to have a benign MS. That said, there are studies that have been looking at people that have benign MS at 10 years, and a percentage of them over the next 10 years progress. So we always need to be vigilant. About 5% of people have very active MS. We call it a malignant MS. We have rapid disability and they're wheelchair bound within a short period of time. Now, what happens if people have MS and we don't treat them? We know this from studies that were done in the past. If you go back to 1990, approximately before we had drugs, remember beta serum was our first drug approved in 1993, so in 1990 we had no drugs. Mayo Clinic did a study, other studies done in England as well, have shown that if you take people with MS, they're newly diagnosed, and you don't treat them, what's their risk? In 15 years, 50% of people have progressed without treatment. This is significant because remember, most people with MS that are diagnosed are young at onset, 20 to 40. Add 15 years to that, you're talking 35 to 50, 55. And 50% of people, what about 25 years? 80% of people have progressed. 80% progression at 25 years without treatment, significant numbers. So again, more reasons why I'm saying to you, we do recommend early treatment to prevent this. And we think our medications, they're not a cure, but we're trying to slow down the progression of the disability. This is, to me, the most exciting slide of all because 20 years ago or 21 years ago, we had nothing on this board. This is showing you MS treatments that are available, and the first drug approved was beta serum in May 1993. And look how many medications we have now. We have actually 11 different FDA-approved drugs. If you consider that there's two forms of beta-seron, there's beta-seron Extavia, and there are two forms of Copaxone, the daily Copaxone, and now 3 times a week Copaxone. We have 11 different medications. We started out with injectables. We moved to an infusion, which was Tysabri. We now have 3 oral medications, and we're on the verge of, we're hoping we have this medication, which is now called Lemtrada. So what you see on the right-hand side over there are drugs. So besides all the approved medications, you can see that we have that drug in the blue called Lemtrada, which is a drug for a very active type of MS that the FDA turned down several months ago. It's back in front of the FDA. We're hoping that they approve it. It is a drug for more aggressive forms of MS. I think it is a right of yourselves and your physician to make a determination if your MS is not doing well to use a more aggressive drug, as long as we know the symptoms and are aware of them, prepare for them, monitor for them. It's a decision we should be allowed to make. And on the top right, you see 3 other medications. The common thing that they all have there is you see they all end in the MAB, daclizumab, or fatimumab, or ocrelizumab. MAB stands for monoclonal antibody. It's a specific class of drugs, which is the same class of drug that Tysabri is in. And these are drugs being developed. These drugs are all in late stages of clinical trials, and we anticipate that at least some of these are going to get approved in the next couple of years. So we're going to have like 15 drugs to deal with in the next few years. They're all active. The more active a drug is, the more we have to monitor it, because potentially it could have more effects on your immune system. Going forward, maybe we're looking for drugs that have less potent effects on the immune system. Next, please. Oh, I've got it, not you. All right, so I don't know what happened. I changed all these slides the other night, and unfortunately, somehow, this is still showing the old slide set. So I'll talk about some of the new things. So this talks about some of the experimental medications. You know that fingolimod is Gilenya. So there are medications in that same family that are being tried. There's siponimod and ponasinimod. I put a vaccine. There's an actual T-cell vaccine. We'll be trying to make a vaccine that's specific for your immune system. There are studies going on with that. If you look at the bottom right there, there's vitamin D3, statins, and tetracyclines. These are commonly available substances that all seem to have some effect on the immune system, maybe, and are important maybe in development. We're studying them for how they affect MS. What I put in the new slideshow that for some reason I didn't get saved is one other drug is Prozac. Fluoxetine is being studied in progressive forms of MS. So that's something else I added. And then the other thing I added to the new slide set, which disappeared somewhere in Atlanta maybe, I don't know what happened to it, but the other thing I added was medications for progressive forms of MS. This is a common question I get. You know, I have progressive MS, because everything we're talking about here is for relapsing forms of MS. But what about progressive MS? Drugs that have been tried, for example, some of the approved drugs have been tried for progressive forms of MS and didn't work in the trials. So there are specific studies that are going on now for progressive forms of MS. There's several drugs being tried, even some of the commonly used drugs. Tysabri is being studied for secondary progressive MS. Fingolimod, Gilenya, is being studied for primary progressive MS. And there are several other drugs in clinical trials, as well as stem cells. So there are now actual stem cell trials. And there are not scam clinics and people out there that are drawing you in, because sometimes we get desperate with this disease if we can't help it. The FDA is sponsoring several studies on mesenchymal stem cells. The very effective site to look at is called clinicaltrials.gov. It's all the FDA-approved studies going on in the US for any disease. Clinicaltrials.gov, you go in there and type in progressive MS, primary progressive, secondary progressive, MS, whatever kind of search you want, and it'll tell you about areas where they're studying mesenchymal stem cells, so we can really tell if this is going to be something effective and it's something legitimate, and it's not just some scam artist out there just sucking your bank account dry, because there are a lot of those. Okay. Also for research, I guess I need to work on the colors of that one a little bit. So this was written in the Momentum magazine, but if you look on the internet, you'll find a lot of stuff about this. A gut reaction to MS, and that's like a play on words. What do I mean? I mean the interaction between your gut, your gastrointestinal tract, and MS. And so that's what this person reported on, the link between the gastrointestinal tract, your gut, and the immune system, and MS. And there's been a lot of studies about this lately. You can do a Google search on it. MS and bacteria and the gut. MS and bacteria and red meat. All these kind of things. So the gut actually is your largest largest part of your lymphocyte system is your gastrointestinal tract. If you think about it, extending all the way from your esophagus, your stomach, your intestines, you've got many feet of millions and billions and trillions of lymphocytes. It's a huge part of your immune system. And inside the gut, there are bacteria that are living, and some of them are friendly. They form what's called a microbiome, just like the biome that you hear out there, which is a specific, maybe geographical area of a specific type of agriculture or plants or animals, is a biome. Inside your gastrointestinal tract, we have a microbiome. There are trillions. Can you think about that? Every one of you here. You have 1 trillion bugs living inside your gastrointestinal tract, and they're mostly friendly. So what happens? Does our diet, how important is the diet? Does our diet modify that? Do medications modify that? How important are those in MS? And so they've done some studies. One was just published, in fact, this past week, that by modifying the organisms in your gut, which is your first line of defense to everything you eat and put inside your mouth, can we modify the immune system and modify our response to MS? Is it possible that if we look at someone's the bacteria in their gut, we could predict the risk for MS, or we could modify their MS? So the gastrointestinal tract, I think, is becoming an important player, and maybe it's going to link in with the diet eventually, that maybe if we modify our diet, we're going to be able to do something with the MS. So making treatment decisions. How do we decide what drug to put you on? Is it easy? Do you come to your neurologist's office and say, I have MS, and he says, here, take this medication? He could do that. I mean, I've seen that happen to people. You know, he might say, I only use drug X. So here you go, take drug X. I like it, take it. Oh, you deserve some option. We should try and look at you and say, how do we personalize this drug for you? And these are things we should look at with every single drug. So you want to look at the safety. Here's another acronym, if you like acronyms like I do. Safety, efficacy, tolerability. You see those top 3 words. So I always say we're going to talk about a set of issues. Safety, efficacy, and tolerability. When I start you on a new medication, I'm going to talk about that. Let's look at the safety of it. Let's look at the efficacy of it. Let's look at the tolerability of it. And now if we think your medication is not working and we're about to switch to something else, we're going to do the same thing over again. We're going to say, let's look at the safety of it. Let's look at the efficacy. Let's look at the tolerability. These are things we look at regularly. How is your drug working for you? But all these other things all around here are very important things, and you can pick any one of them. What's your preference? You might say, I like a pill. I don't mind an injection. I want something that's been around a long time. It's got good safety. There could be a pregnancy issue. Young woman, childbearing age, could be a pregnancy issue. And it doesn't matter what I think or you think. Sometimes the insurance company will come into it and say, what about the cost? So there could be many different things. How do we monitor? How do we screen? So this is a complex thing that we're thinking about every time with these medications. So it's like I said, this is what I talk about when we start a medication and when we switch to another medication. We talk about relapses. How do we know if your medication is not working? Are you having relapses? Has your disability progressed? Has the MRI scan showed progression? These are the things we look at every time. Safety, efficacy, tolerability, cost and convenience. What does the insurance company say? This is a standard page that I'm going to be looking at when I start the medication. It's the standard page I'm going to be looking at when I switch your medication. So this is similar stuff. This is switching, the same things we look at again, but the sequencing sometimes can be important. Some drugs have effects on your immune system, and you might have to wait a while, so you have to pick which drug am I going to take first because of the effects of a drug. So sequencing could become something important in the future, especially that we've got so many new medications that have potent effects on the immune system. Now, how do we match you with the treatment? This is something I just want to put all these things up. The reason I put this up is because you got the opportunity to look at it on YouTube. I'm not going to go through each one. But there's many things that we have to think about. Again, what I'm saying there, the way I would summarize this slide is I'm trying to personalize the medication for you. What's best for you? What does it depend on? What's the severity of your disease? What other conditions do you have? Could that influence the drug I'm going to put you on? What's your risk tolerance? Childbearing potential? What's your immune system like? There are many things we have to look at. How about your medical history? Again, a long list. I'm not going to go through it all, but there could be things. Some of the drugs might have an impact if you have underlying liver disease. Have you got liver disease? Do you have a history of depression? Some medications may increase your risk of depression. In people with MS, we know there's a higher risk of depression to begin with. So if a drug has a risk for depression, we need to make you aware of that. You need to make your family members, your support group, they need to be aware of it too. Sometimes they might be the first to notice there's some changes. It's very important. Depression is a big problem in MS. Are you diabetic? Do you have heart disease? I spoke to you before. Earlier I said that in people with MS there's a higher risk for these things, for cardiovascular, cerebrovascular disease. there is a higher risk of these. We need to be on top of it. So I need to know all your medications. When you come in and give me a list of your medications, I need to know everything. Are you taking a statin? Are you taking something? Is your diabetes under control? We need to know all those things. Infections, varicella history, these apply different things to different drugs, but these are some of the things, some of the items that we go over. What about your lifestyle? Could that be important in picking your drug? Your age, the side effects. Some people have a greater tolerance for side effects than others. Your childbearing, we talked about employment. Whether you work or not, or where you work, or how you travel could be important in what you decide to pick. And your support system, finances, insurance, and compliance. We're going to talk a little bit about compliance. And how do we monitor you? What monitoring tests do you do? Do you like to go for a lot of tests? Do we need to check your liver and check your blood count? Do you have to see an ophthalmologist? Do you have to see a cardiologist? There could be many different things that we have to monitor for. So in evaluating your drug, we're going to say how much monitoring do we have to do? Safety and tolerability. Again, I listed them. You're going to have the opportunity to look at them in more detail, but there's a lot of different things. If you think about all these drugs we have, we've grown up as neurologists. As MS neurologists, we've really grown up. We have to be aware of these things. In 1993, like I said to you, at a time when I was in practice, I know you all think I'm like only about 25, but I mean, in 1993, when we started dealing with these drugs, we had no drugs before that. We didn't have to worry about these things. I didn't have to worry about giving you a drug that causes flu-like symptoms or depression or might affect your heart or your eyes or some other organ in your body. Now we have to know about all these things. We must be aware of all of them. And we must be aware of interactions between them and between other drugs. What about the adherence to MS drugs? So this is a study done in Canada where they have a captive system like we may have, which is namely it's national health. So they know everything that everybody's taking. And look at that, at 2 years, about 50% of people were not taking their injections as prescribed. And different studies have shown different things. Some say 30%, 70%, but about 50% of people have stopped taking their medications. Why? Why have they stopped taking their medications? This could be some of the reasons. They don't like needles. Okay, we have options for that now. They might have side effects. They feel the medication's not working. Depression, people that have depression have a higher dropout rate from taking their medications. And so it's very important that we establish realistic expectations. That's a very important thing. I need to say to you and discuss with you, have the discussion. What are we expecting this medication to do? So we go back to the 3 things we talked about at the beginning. The medication should slow down your relapses or stop you from having relapses, slow down the progression of your disability, and improve your MRI scan as compared to someone who wasn't on treatment. That's the expectations. It's not a cure. If you have symptoms already, if you have a bladder problem or a bowel problem or fatigue, the purpose of this medication is not directly toward your symptom. So realistic expectations are very important. Someone would come back to see me in 6 months and say, I stopped the medication because it's not working. I say, well, how do you know it's not working? I'm not walking any better. My bladder still bothers me. I still have fatigue. That means I haven't conveyed to them what this drug is supposed to do. It's supposed to slow down the progression of your disease. I need to take you to the symptom tower. That's where we're going to deal with your symptoms. I'm saying today you're going back on your disease-modifying drug and we're going to the symptom tower. Let's make an appointment. We're going to talk about your bladder and your fatigue and your pain and things like that. It's a different building. We need to go there and visit there. So how can we improve your adherence? Mostly what I've just said is establishing realistic expectations, making sure you understand what the purpose of the medication is. And if you have a side effect, let's deal with it. Call your physician. Tell them that you have a particular side effect so they can deal with it. Many side effects are manageable. How about polypharmacy? That's a very important thing. Because you could be taking a bunch of medications. You're taking something for your MS, one of these disease-modifying drugs. You're taking something for your MS symptoms. You're taking something for your bladder, maybe for pain, maybe for fatigue. I mean, at the end of the day, all of a sudden you're on a bunch of medications. And you could have other conditions. You might be diabetic. You might have some other condition. Now look at all the opportunities for different problems if you take so many different medications. So this is some of the drugs that can be used to treat MS symptoms. Look at all the medications you could be taking. So do you think with all these medications you're taking that there could be some risk for some interactions? What do you think? Absolutely. And that could be what's causing your problem. So you could be okay, except we talk about your bladder and we say, okay, let's start this new medication for your bladder, and you go home and you take it, and guess what? In 4 days' time, you're a little bit confused. Your mouth is dry. You feel a little dizzy. And so you call me on Friday night at 6:15, because that's the usual time you call when you have a relapse, right? And you say, I think I'm having a relapse. And I say, if I know you, I say, well, let's see, what new medication did you start this week? And you say, I started something for my bladder. And I'm saying, well, let's stop it. So we have to think about other things. This just shows you opportunity for interactions between all these drugs. Polypharmacy. Factors contributing to polypharmacy. We kind of talked about that you could have chronic diseases. You could have multiple prescribers. They're all giving you different drugs. Everybody needs to check what you're on. And you'll see I'll emphasize that at the end. And then the dosages could be different. You might need a lower dose. The dose could be different for different people. And we need to monitor it and follow up properly. And we both have a responsibility for that. I do and you do. You need to keep appointments. I need to make appropriate appointments. And so I'm going to the self-help section now. I'm just going to fly past this slide. You'll see it on YouTube because this is my old acronym for self-help. And this is my new acronym for self-help. This is the most important thing. This is when you're part of the team. So you're seeing the neurologist. We've established now you're on a drug for your disease. We've talked about your symptoms. I'm saying that's not the end of your work. These are all very important things to deal with. Temperature. Are you heat sensitive? How do we deal with that? Do you need a cooling vest? We talked about that for your exercise. You have to exercise. It's essential. So if you can't do it, you're too hot, maintain, monitor your temperature. This has been a particularly warm summer. I'm sure it's been warm up here too. Like I read somewhere, I think it's the warmest summer in like 100 years or something. Temperature, very important. Expectations, we talked about that. Have to have realistic expectations. Adherence, we need to talk about how important it is, because guess what? I'm going to say something very obvious. If you don't take the drug, it doesn't work. And I see that. People come and see me, I say, well, how are you doing? I haven't seen you for like 9 months. Oh, I'm not doing well. Well, it looks like your medication's not working. Let's start looking through all these things and picking a new drug. And then at that time, usually I get what's called the eye gaze sign, which is looking up at the sky or looking away. And now it's confession time. Now I put on my robe and they confess. And the confession is I haven't taken my medication. Why? Well, I got too many reactions. Why didn't you call me? Or the other one is the insurance stopped. My insurance ran out. All these companies have financial assistance programs. I stress that. Don't stop the medication. Call me. Let's see if there's something we can do to help you. So adherence is very important. We talked about mental aspects. Working with your memory. That also could include mental aspects of cognitive functions. It could include memory. It could include other things, depression and things like that. Sleep, the importance of sleep. And you see again the same theme again, all these things interacting with each other. Your outlook, a positive outlook undoubtedly helps. Not everybody can have that. I don't know if you can acquire that, but a positive outlook undoubtedly helps. And then the management of fatigue. And food, your diet. We could spend an evening talking about that or an afternoon talking about food. Relationships are very important. People that have strong relationships do very well. And interactions. This is an interaction. So support groups are interactions, peer-to-peer discussions, interaction with other people, with your neurologists, very important. And exercise we spoke about, and news. Many of you have heard of something called MS Views and News. And I say that every time. It's obvious that the news you get is very important. That's what Stuart does. That's invaluable. Now you get news from other sources. The MS Society sends out newsletters. The MS Foundation has a great magazine. The MS Association of America, they all have great magazines with lots of good educational stuff in them. So get them all. Vitamin D. That's got a separate section from food because of the importance of vitamin D. And smoking, a major risk factor for MS. And this is what I call defensive nutrition. Eating properly, like defensive driving. Calorie and content control. Not only watch what you eat, but watch the amount of calories. So you could say, I'm a vegetarian, so I eat healthy. Yeah, but that doesn't mean you're necessarily healthy. You could eat sugars vegetarian. You eat too much of that stuff or too much fat. So what you eat, both the calories and the content are important. And sharing portions. You don't have to eat the big portions that are always provided. Who should you share with? Who wants to know who you should share with? Yourself. That's what I say. Share with yourself. That's the first person. So typically, I think when you go to like Italian restaurants and order some pasta, there's a huge bowl. It's enough for a family of 8. So I'm saying share with yourself. So the first thing I say to do is when they bring the food, ask them right away, tell them to bring me my little styrofoam box and divide it in half. Take half of it away, put it in the box, you got another meal, and take what's on your plate and spread it out. I guarantee you there's going to be enough. So share with yourself or someone else. Don't skip meals. We know that's what everyone said. I guess that's what our grandmothers taught us, allegedly, or what we say to our grandchildren. Salt, sugar, and fats. So salt. What about salt? Is salt important in MS? Is it important in your general health? Yes, most important. Just like I stressed vitamin D, salt is very important. So they've done studies where they've looked at the amount of salt in the diet, and they found that if you have low salt, people that had low salt intake had less relapses and less progression of disease than people that had high salt intake. So I need to speak to Stuart and say, when we have a meeting like this, there should be no salt on the table. But maybe people won't like me very much. But salt and sugar, you know, is a poison. I don't have to tell you about that. We all know it's a poison. And fat, what's the fat fact? Dr. Swank, the Swank diet, the original MS diet goes back and says avoid saturated fats. So try and have a diet that emphasizes unsaturated fats. You can eat healthy fish if you want, fatty fish, salmon, halibut, cod. Fatty fish is good. You can have a snack, a handful of nuts, some nuts. Unsaturated fats is what you need to do. More fiber, more plants. Your diet should be a plant-based diet. Lots of fruits and vegetables. And fluids. All these things now you see where they're coming in. Fiber, more fluids, a plant-based diet. What's a major symptom of MS? Constipation. You're dealing with it now. You're starting to deal with other aspects of your symptoms as well. Watch out for alcohol calories. Yes, you can have some alcohol. It's got a lot of calories. I said right at the beginning about calories. And then supplements. Vitamin D and B12 are the two important ones for MS. Here's some of the plants. And this is from Dr. Joel Fuhrman. Some of you may have seen his shows on PBS or read his books. They're excellent. They're all very good. If there's a show by him on PBS, watch it. He talks about all these things over here. And I think he's got a name for it cool. His acronym is COMBS. COMBS. Just eating a diet that's got a lot of fruits and vegetables in it. Now, what about vitamin D? We feel that vitamin D is actually an immunomodulator. It actually has some effect on your immune system directly. Very important. There are vitamin D receptors widespread in the body. So beside MS, they have studied vitamin D for other things. A recent study said that vitamin D didn't seem to have any effect necessarily on cardiovascular disease. But this week, this last few days, there was a study on vitamin D and dementia. And they said that people that had low vitamin D had a higher risk of dementia. That is published this week. Now, I have no idea if someone in 6 months is going to say it's not true. But there's another thing about vitamin D and dementia. And it's in many cells in the body. And if you ask me how much to take, I say we have to measure your level. That's how we know how much to take. We said there the level should be about 75. 70 to 75. We're aiming for a high level. If the normal range in most labs is 30 to 100, and your physician might say, well, you're 45, you're good. No, we want it higher with MS. We like what we call these vitamin D receptors to be saturated. We feel that's important for MS. Now you see the third bullet point down there. Vitamin D serves as a prognostic indicator for conversion to definite MS. So what they looked at is people that were diagnosed with MS and had low vitamin D, and the lower their vitamin D was, the more likely they were to develop definite MS. And there was a study shown last year in the big MS meeting in Europe. The study was actually done in Boston, where they correlated the MS progression with the actual vitamin D level. So people that had a vitamin D level above 50 had about 1/3 as many relapses as below 25. Significant reduction in the number of relapses. Salt we spoke about. I'm not going to go over this again. This is some of the references. You can look at it on YouTube if you want to look at some of the references that I think are helpful in eating healthy. The Blue Zone is a study where National Geographic commissioned the author to go to areas of the world where people lived a long time, especially the males. In our Western societies, mostly the women outlive the men. But in these areas where he went, these 4 areas, the men outlived the woman. And he found out certain things about them. One thing he found is that they had a vegetarian-based diet. And it wasn't because they wanted to be vegetarians, because they couldn't afford it. They couldn't afford to eat animal product, for example. Also, he found other things about them. They were physically active. Even at old ages, they were physically active. He gives an example of hand wrestling a man who was 90. He was 42 at the time of writing the book. The man beat him. And the third thing was that they all had a sense of purpose. So I say that to you, have a sense of purpose, whatever it is. Have some interests. It doesn't matter what they are. It doesn't matter if somebody else likes them or not. Have some hobbies. Something that interests you, that sparks you each day or each week to look forward to, a sense of purpose. And then there's some other studies over here. You can look at them all over there. I won't repeat them. And some authors at the bottom that have written some good books and good articles on the internet. And I think if you want to really research nutrition and diet, you can look at those. Here's another thing about diet. Body mass index and weight in young adulthood are linked to younger age of MS symptom onset. This has also been published. So let's look at some risk factors we've talked about. You have MS. So your family now has genetic susceptibility. You have kids. They're growing up, they're adults, they have genetic susceptibility. What are things we know about that could increase their risk? We spoke about vitamin D. Make sure that they're taking vitamin D. We spoke about smoking. Make sure they don't smoke. Here's another risk factor: obesity, increased body weight. So in teens and young adults, if they have increased body weight, it increases their risk of getting MS. You can see these two studies. An analysis comparing overweight and non-overweight persons. Those who were overweight at age 25 had a significantly earlier age of MS onset and diagnosis. So we have some place to try and intervene with people and say, let's work on your diet. It doesn't happen overnight. It's like smoking. If I say stop smoking, I don't expect you to come back next week and stop. It takes time. And make it your lifestyle to eat healthy and take the vitamin D and don't smoke. So there's some studies over here about the body mass index, smoking. I'm not going to go through this. We talked about it. This is more detail about it. Looks like this one got in twice. And this is where I'm going to end here, is with the office visit. It's a summary of everything we've said. It's the importance of your office visit. It's the time when you go in and you're face-to-face with your neurologist. Make it of value. Make your visit valuable. And so how do you make your visit valuable? What I do in my office is that we have sheets of paper, and when people leave after a particular visit, we give it to them so they can fill it in before their next visit, so they don't have to be labored and come into the office, and often they may be late and they don't fill it in properly. And so this sheet of paper says 3 basic things. It says, number 1, why are you here today? What is your chief complaint? It could be, it's my annual visit. Great. It could be, I have new symptoms. I want to know about that. You write it down there. Secondly, it says, what are all your other symptoms? And there's a list of them all. Numbness, weakness, fatigue, bladder problems, bowel problems, depression. All of those symptoms are listed. And it extends beyond that. Then it says, what's the rest of your general health like? Do you have any heart disease? Summarize it for me since your last visit. Is there anything new going on? How's your cholesterol? Are you diabetic? All these symptoms, bladder, everything is covered. That's the first set of things. The second set of things we ask on this form is, what are your medications? Tell me all your medications. But not only all your medications that I'm giving you, all your medications, everything, and your supplements. I want to know if you're taking vitamin D. And please don't write same or unchanged. Because what do you think same means? Same means maybe there's only 1 or 2 different. It's never the same. It's hardly ever the same. Let's put it like that. Put them down. And then the third thing on this list is the questions. What are your questions today? You've put down your symptoms. You've told me your medications. Now I want to see what are your questions today. Your question could be, I have sleep problems. I do not want to get a door question. Do you all know what a door question is? That's when I've spent 30 minutes with you maybe. And now we're about to go. We're out the office. It's busy. And as we go out the door, I say, I forgot to tell you about my bladder. Wow, this is a 1-second discussion. 1 second we're going to talk about your bladder? No. I forgot to talk about my fatigue. These are complex things. We need time. Write them down on your list. So you put these things down, and you put this piece of paper in front of your neurologist, and he looks at it, and he can see in 30 seconds what he needs to talk about. He can see your symptoms, summarize your history, look at your medications, look at your questions, and now the visit becomes a high-value visit. You've made it from a drag-out, slow extracting visit. I'm not a dentist. I don't specialize in extraction. You know, it's tough for me to extract. And when you see, 12, 15 MS patients a day and you're extracting all day, you get worn out. And you could become an alcoholic. Not really, but it's tough. Make it easy for yourselves and for me, and make it a high-value visit. Tell me all those things. And then I'm going to ask you at the end, we've been through all that stuff, we've answered your questions, we've looked at your medications, and then I'm going to say at the end, what do you think I'm going to put in my electronic note? What am I going to write down today? Sometimes I'll ask them, summarize for me what I'm going to write down. They might say, well, stop smoking, exercise, take vitamin D, get some lab work, go and see my endocrinologist, see my primary care doctor. I'm saying, well, if you give those things back to me, I know my visits had some impact. And if you don't, I'm going to summarize them for you. I can actually print them out from you electronically and say, this is what we accomplished today. So the office visit is the time to put this all together. It's a very important visit. Make the most of it, and write those things down like I'm talking about. And I'm working with Stuart. Maybe we'll do some derivation of that so you can do it generically if your own doctor doesn't do that. But I think that's a most important time in your MS, in your land of MS, in your lifestyle, and your living. And that's it for today. Thank you very much.
Thank you, Dr. Brian Steingo, for those words and the message you brought. Now comes the part of the program that most of you enjoy other than the dessert, and that's the question and answering. What we'd like to do is go around. We'll start, if you would, just raise your hand. If you have a question, I'll come over, and yes, I will be putting the mic in front of you, but you will not be videoed. It will just be your voice captured on the program. And we'll limit our questions to one at a time, and then if we have time at the end, we'll come back around. You ready, Doctor? All right.
Hi, thank you. I'm Carol Hall. I'm from Alabama and Daphne. And I need to ask you a question because I just had a third cousin that was diagnosed with MS. And so there's me, so there's 4 of us now. And I was wondering, because when I talked to her a couple days ago, there's all this talk up in the Northeast, because I'm from Massachusetts, about Lyme disease and maybe misdiagnosed with Lyme disease and MS. And I was wondering, like, is there a specific test they do for Lyme disease? Or I thought there was some kind of teeter test or something, but I don't know. They're saying it's not good enough or something, and maybe there's misdiagnosis.
So there is no specific test for MS. So you can diagnose rheumatoid arthritis or thyroid disease by doing some blood tests. There's no actual blood test for MS. So our diagnosis is made by combining your symptoms and your scan and sometimes the spinal fluid. But there are many things that mimic MS, many diseases that mimic MS, like lupus and like Lyme disease. So when I see someone for the first time, when most neurologists see someone for the first time, we want to do blood tests to rule out the other diseases, like Lyme disease, because Lyme disease can mimic MS. Potentially, you could even have both. But Lyme disease can mimic MS, and so you need special tests. So you start out by doing some routine tests, and if they show anything suspicious, then I normally myself would send someone to an infectious disease specialist to do the more sophisticated tests. But it can be one of the mimics of MS, and it should be ruled out. Lyme disease, as such, is not a trigger of MS. If you have Lyme disease, it doesn't trigger MS. You could have symptoms of Lyme disease or symptoms of MS, 2 separate conditions. But if there's any suspicion, then you need to do the special test, and that I would send someone to infectious disease specialist to do that.
Is there a lifespan on your MS meds? Like I've been on the one I'm on for 14 and a half years. I'm now, especially after today and listening to some of the things you're saying, I'm realizing that I'm starting to feel things a little different. So do I need to change or?
Well, the lifespan really, we would say that old cliche, if it ain't broke, don't fix it. So if you're taking a medication, even if it's an old medication, I wouldn't necessarily change it. There's 3 reasons, the same 3 things that I talked about in this slide repeatedly that make you think about changing. So I talked about, remember the SET, S-E-T. So there's 3 reasons why you think about changing your medication. So the first one could be safety. So if you say, I've had some blood work done or some lab work done or something done and the medication's not safe for me, that's a reason to switch. The second reason is the E, efficacy. It's not working for me. I'm having relapses. I'm progressing. That's efficacy. And the third one is tolerability. You're saying, I can't tolerate this. It gives me too many symptoms. So if you have those 3 reasons, that's when you start to think about, is it time for me to switch? Safety, efficacy, tolerability. So if you have one of those 3 in what you're feeling, then it's time for you to have the discussion with your neurologist about switching to something else.
Hi, my name is Irene Julian. I'm from the Fair Oak side. Anyway, I need to know, I have, when I start doing things, like walking or working in the yard or whatever, I notice that I get lightheaded and my voice starts slurring and my eyes get real weak. Is there anything I can do to prevent this?
So everybody heard the question, I guess, because we've got the mic. Yeah, so it depends what the cause of it is, but one of the causes could be, you said, it's when you start to do things. So potentially, sometimes it could be because someone is active, especially if you're outdoors, and it could be heat. People with MS can be very heat sensitive. And heat can increase a lot of symptoms. So if you've observed this as happening when you're going outdoors and your body's heating up, then you can try and keep cool, like get a cooling vest or something if that's when it's happening. Lightheadedness is a very non-specific symptom. There's many things that cause lightheadedness. So if someone has lightheadedness, then I'm also going to say, let's make sure there's no medical issue causing it, that there's nothing with your heart, you're not having an irregular heart or something. I would always want to rule that out. And then there's a small group of patients that actually have lightheadedness from their MS as well. Lightheadedness, dizziness from their MS. So there's a variety of different things to look at.
About the, I know there's no reasons what causes the MS to activate, but have you ever heard of like a major surgery, things of that nature being a causation factor for the MS to activate in a person?
Yeah, so the question is, if you have MS, what triggers it off? So there used to be a time when they used to say, and still people, write to us when someone's going to have surgery, the physician will write and say, I need your neurologist to clear you, because we're afraid that the surgery is going to activate your MS. For the most part, that doesn't happen. Most people, as long as the surgery is straightforward surgery, whatever it is, if it's uncomplicated, they usually do fine. The problem with surgery is that surgery is stress to your body. And any kind of stress can activate your immune system, so there is some potential that it could activate your MS. That would usually happen if something happened with the surgery. If you had surgery and you had a complication, you had an infection, you had a lot of bleeding, then that could activate your MS. Most people with MS are able to undergo surgery and do fine.
I was actually talking about not being diagnosed yet and having the surgery and then becoming diagnosed.
That could happen, yes. In other words, that's stress, any kind of stress. So stress is important for the immune system in general. So if you've had a stressful period because you were sick and you had surgery, sometimes people will say that they were sick, they were in the hospital, and they came out the hospital and their medical condition is better, and they suddenly started noticing trouble walking. Yes, some kind of stress to your body could activate the immune system. Sure.
Hi, Jocelyn Donahue, and my question is, vitamin D and B12, what dosages should we be taking per day?
Yeah, so the good thing about vitamin D and B12, vitamin D is very specific for MS. I told you before you need to measure your level, and the level we're aiming for is 70 to 75. So get them to do your blood test and then find out what the level is, and we want it to be 70 to 75. Then I can tell you how much to take. Some people take 5,000 a day. Some people just need 2,000. I have some patients who take 10,000 a day. But the level is crucial. And the same thing with B12. B12 is not specific for MS, but it's a very important vitamin particularly for the nervous system, also for other systems in the body. The same thing. You can measure the B12 level. We want that to be over 400. And so if it's not over 400, then we need to supplement your B12. And both of these can be measured. You can measure them so you know how much you need to take. But they're both important.
I've read a couple articles about men in the late 30s with low testosterone triggering MS. I wanted to know what your feeling was, and do you supplement your patients that you see?
Right. So there are studies going on both in men and women with hormones, sex hormones. In particular, there's a study with estriol, which is a female hormone, and also there's been small studies with testosterone. So there's no major large-scale study. But small studies have reported that in men with low testosterone, if they boost the level up, then they sometimes will feel better. Most men that have the lower testosterone have other issues as well. Particularly, for example, they may have sexual dysfunction. Oftentimes I refer them to a urologist to deal with that. They measure the testosterone and it's low. And they give them the testosterone to improve sexual function, which it sometimes does. And then after that, they often say they feel better too. So I'd answer that and say there are small studies that suggest some benefit of maintaining adequate levels of sex hormones. So it is something worth doing if someone has fatigue, particularly, for example. If you have fatigue and we're looking for causes and no other obvious cause, then that would be something worth checking.
Okay, I'm Bill Schatzel from the Charlemont Group, and I'd like to take you back to your experimental medicine slide. You had tetracyclines down listed as one of the experimental medicines, which I believe is an antibiotic. So how are antibiotics or tetracycline playing into MS treatment?
Yeah, so it's not having that effect as being an antibiotic. We find that the tetracycline, such as minocycline, is a form of tetracycline in that family, has some the drug itself has an effect on the immune system. And the same as I mentioned to you, fluoxetine, Prozac, these drugs have other effects in your body. They work in other areas and have effects on the immune system. So the effect of minocycline is an effect on the immune system. Unfortunately, those studies have been very limited. You can imagine why. These drugs are antibiotics. There's generics. They're cheap. Who's going to do a study like this? So there are very few studies. But there is some promising evidence. So these are ongoing studies. So this is not something I would give to somebody. I wouldn't give you tetracycline or minocycline because it could help your MS. There's not enough evidence for that. I would certainly, if you're on it, I'd be interested to see what happens. The same as with the statin. There are studies that have shown that the statins help MS. Recently, they published a study that showed that statins actually may slow the progression of progressive MS, secondary progressive. But the dose they used was very high. So again, if someone's on it, I'm happy to see what happens, but I wouldn't give it to you just because you have MS. There's not enough evidence for that yet. So it's the reason for using all these drugs is because of effects they have on the immune system. Not because they're antibiotics, and with the statin, not because it probably lowers cholesterol, but because they have some other effects on the immune system.
Hi, Connie Stewart from Pace, Florida. I was just curious, how often do you think you should have an MRI? Once a year? I don't know.
Well, sometimes it's not up to us. Sometimes the insurance company tells us what to do. But we do MRIs more frequently early on. So if you're newly diagnosed early on, I want to know how you're responding to your medication. I might do it at 6 months, I might do it at a year, I might do it at 2 years, and then 3 years. And now if you start to become very stable, then I might start spreading it out and doing it less frequently. So the answer is more frequently early on, and as time goes by, when you're very stable, it becomes less frequent.
Hi, I'm Joanne from Alabama. I recently had an MRI, and the only thing my neurologist said was, based on the MRI from 2 years ago, no disease activity, which is great. I assume my drug is working. However, if that's the case, why do I feel like I'm worse now than I was 2 years ago? Cognitive function's worse, fatigue is worse. Similar to what that lady was saying, if I try and do anything, I get weak, I'll start shaking, and it's both inside and outside, so it's not just the heat.
So what have you just? So what did you just describe to me?
Well, I didn't want to say had a relapse, but...
No, not a relapse, because you're gradually getting worse over 2 years.
Right.
You
I'm
described
progressing.
invisible symptoms.
Correct.
You're right, remember? We talked about those. Cognitive problems, fatigue, they're invisible symptoms. They're hard to see. And they don't correlate always directly with a scan. For example, if you have a cognitive symptom, I can't look at your brain scan and say, well, there's a spot there, so you're going to have a cognitive problem. It's different. It may be in more than one area, maybe in multiple areas. So it could be hard to measure something like that. So sometimes like that, if you're having memory problems, it might be worthwhile to do some simple memory testing. And that's a way of measuring you. Because we can measure that. We can do some memory testing and maybe follow up and do it over time. The MRI scans don't show everything. What the MRI scans show very well is white matter of the brain. What they don't show us well right now is the gray matter of the brain. And if there are problems in the gray matter, which could affect memory, for example, we don't see them well on our current scans. In the future, we're going to have techniques that will show us that better. And then also make sure you do a scan of your spinal cord. It's an area where you could miss something. It could be something, they could do a brain scan and say, well, it's no worse than it was 2 years ago, but how about your spinal cord? How does that look? That could make you feel weak and fatigued as well. And then the other thing, I would also always make sure that your general health is good too. So I would make sure you got all the appropriate scans, including your cervical, check your general health, check your thyroid, and look into the memory aspect of it. Is it declining as a measure? And if it is declining, then do we need to change your medication? Do we need to work more on the memory itself?
First of all, thank you very much for your representation and the information you gave us. It's very helpful. I'm getting Botox injections for my spasticity, and one of them is to keep my toes from curling under. But this time we went a little bit too far, and so I'm kind of in trouble. And I'm wondering if there's something to speed up the wearing off of the Botox, or if it's just a matter of time.
Yeah, so Botox reduces muscle spasticity, which is muscles that are very stiff, and what it really is it's a muscle poison. So it loosens up the stiffness. And the side effect of that is that it can cause some weakness, which is what you're describing. It causes you to be weak. The good news is that it recovers, but there's nothing to speed that up. It's just got to take gradual time to come back again. That's one of the problems with Botox, causing weakness.
That's the first time I'm in trouble with it.
So maybe next time, if you do it again, if you venture out again, they give you a lower dose. Yeah.
All right, we have time for a couple more. Anybody?
Jean is always, she's in the bathroom right now, but she is always cold. She's got a sweater on right now in here, and it's warm to me. What's making her so cold all the time?
There are some people that just feel cold. So it could just be her makeup. I'm sure there's other people in here that'll tell you they're maybe cold or warm. Warm? Hot. Hot. This is a fight I have at home all the time. When I come home, I put my air at 78. And my wife walks by and puts it at 72. It's a constant battle that goes on. I like warm. So some people just have a makeup like that. On the other hand, you have to look at other conditions as well. For example, I talked about thyroid. People with thyroid disease commonly feel hot if they're hyperactive or cold if they're underactive. So make sure that the thyroid is okay and that medically she's okay. The other thing is that you could say, could it be from the MS? Yes, it's possible. There's a part of the brain called the hypothalamus, which regulates temperature. It's rare for the hypothalamus to be involved with MS. So actually to feel just hot or cold because of MS can happen, because everything can happen, but it's rare. So always look to other things.
I got another question. My right arm hurts right in here sometimes, and it's usually right after or when I'm sleeping and when I'm relaxing like now. It just it's not a hurting pain, it's just and not a numbing pain, it's just a pain.
So, it's a question of pain. You can get pain from MS. We talked about that. Usually if you have a pain in the arm, it would correlate with something in your spinal cord. But there are other things to look at. It's very common that you could have pinched nerve in your neck, for example. So we need to look at your MRI again, like we talked about before. Look at the MS, but also look and see if you've got disc disease, bulging discs, herniated discs, nerve pinched in your neck. Do you have any nerve problem in your arms? We should check that out. Could you have a pinched nerve somewhere? Could someone have a carpal tunnel or a pinched nerve somewhere? So there are other things to look at. So what I say is when you have MS, the one thing that we see quite often is that someone goes to see their physician and they say, well, go and see a neurologist, that's from your MS. And I say, no, it isn't. Because you have MS doesn't immunize you from other diseases. Let's always make sure we're not missing something else. So that could be one of those things. I might check something else and say, well, let's just rule out the other things that could be treatable or managed differently. Let's look at your neck, let's look at your nerves, let's do a nerve test. And if we find nothing with those, then maybe we give you something, try and treat your pain.
All right, one more.
One more.
And obviously I don't expect a specific answer because, med lists and all that stuff. But since I've been diagnosed with MS, I've added a few medications to my listing. And I've acquired a new thing that I've never had before. I have a CPAP. I sleep with it constantly. I get up in the middle of the night to use the restroom. I fall asleep and fall over in the tub. And I do it once, twice, 2-3 times a month. And I have no idea how to stop it. It does not matter what I do. I didn't add anything heavy, nothing. And nobody can figure this out. Have you ever heard something like that?
Well, I've heard it, if people with MS commonly have sleep disturbances. That's why I showed you that slide, specifically about the sleep apnea. And sometimes people with MS have hypersomnia, which means they sleep too much. And typically, sometimes people, if they're fatigued and exhausted, they'll go to the bathroom and they can't fall asleep. It just from excessive fatigue and tiredness. Maybe you're waking up out of a very deep sleep. So again, to me, what has to be managed and what you've just said is your bladder. The problem with what you described to me is your bladder, because your bladder needs to be better managed so you don't have to get up at night, because you've got a sleep problem, a big sleep problem. And I guess the CPAP's checked, it's working. Is it working for your sleep apnea? Yeah. I'd say, why are you waking up at night? I'd want to try and get to the step before you go to the bathroom, because you're obviously getting up and you're exhausted and you're just falling asleep and falling over. And I'm saying, I would like to see, can I do better with your bladder? Can I do something so I can shut your bladder down so you don't have to get up 3 times at night? That's what I would be working on, I think.
All right, and I have just a general question for you. Since your involvement with MS and MS News and Views, and over the time seeing that the patients, have you noticed that the quality of patient education has grown, stayed the same, or been limited in recent years?
No, patient education has changed tremendously. If you go, firstly, the internet was the biggest, before the internet, how did you disseminate information? Even to get people to meetings was very difficult. So the internet is huge. That's I think the way many people get educated. And despite the internet, people still come to meetings. Like, they still like to get educated. So I think, yes, there are great educational opportunities. And then what Stuart does, I mean, he advertises. I don't want to do more commercials. He already did a 20-minute commercial. And that commercial tells you what he does. It's fantastic stuff. I refer my patients. So if I see a patient and they say to me, what about diet? So they bring their long list and we're going to talk about diet. I will talk to them partially about diet, but then I will refer them to MS Views and News and say, go and look at the YouTube where I did a talk with Stuart in Boca or somewhere, and I spoke about diet. And go and get some tips from that. That's the things I want you to work on with your diet. So I'll point them to the YouTube. Then if I see a patient who's newly diagnosed and I talk to them about drugs, they hear my input, the medications I like, but I say, go to MS Views and News, because you're not only going to see me speak, you're going to see Chris Leganke speak, and you're going to see other doctors in other areas, so you get different MS experts talking to you about the medication. So I think in that way it's invaluable.
Thank you very much for another excellent talk. So, again, everybody, thank you for coming here today. Please be careful when you're exiting. And again, we want to thank Dr. Brian Steingo for making it here a long trip in.